I thought uh, I wanted to show one important concept here to follow up on Dr. Sayance's presentation. So, the whole history of atrial reentry, starts many years ago. I want to, focus specifically on complex flutters in this presentation. So what I'm going to show you is, I'll skip the real basic science and I'll come to the part that is very important for us, and that is how these circuits are created. So atrial reentry can either be functional or it can be anatomical. And I think in many of these cases what we have to remember is previous ablation or previous surgery causes an area of slow conduction, as we all know. And the interaction between areas such as the Bachmann's bundle, which you presented, the pectinet bundles, scars, and annulae of valves are all incredibly important for catheter ablation procedures. And specifically when you looked at any of the experimental settings out there, pectinet bundles, scars, all of them tend to be, so sorry about this, my mistake. They tend to be areas where reentrant circuits can anchor themselves. And this is one of the reasons why sometimes you see both flutter and fibrillation coexist in post-MACE and post-cardiac surgical patients. And this has, of course, been shown. This is a classic paper that was done almost 20 years ago by T.J. Wu, who worked with Peng Chen back at UCLA and Cedars. And they actually have mapped this in sheets of atria, which is what is shown over here. Now, this story is relevant to what we are talking about here today because the circuit size sometimes can be very small for some of these arrhythmias, and which is one of the reasons why you may see post-MACE and post-AFib flutters have an extremely small circuit, and sometimes your activation map may actually look like a focal activation. So don't be surprised when you go into the lab, especially with things like arrhythmia these days, you're going to identify more and more of these microcircuits, which of course has a lot of relevance because if you have more than one microcircuit, sometimes we've even seen two competing tachycardias in patients who have had post-MACE or post-AFib flutters. And of course, fibrillation is the most extreme where the mapping itself, the interpretation gets very complex. So let's now look at one specific example to follow up on Lewis's case, and that is what happens in patients with reentry. I just wanted to make 2 points before we get to the lab. It doesn't matter what post-MACE or a post-AFib flutter that you're dealing with. Remember one thing, common things are commoner. You're very likely to deal with two areas. If people have had left atrial instrumentation, you're going to be dealing with a mitral isthmus problem. And of course, never ever forget that the tricuspid isthmus, even in presence of congenital heart disease, ends up being the commonest circuit for flutter. So, and another point to keep in mind is, when you're ablating these post-MACE flutters, it's nice to actually have multiple activation sequences. And this becomes, of course, in this institute, and hopefully we'll have more cases in the future years to actually show you congenital cases, because during a procedure, one flutter can entrain another flutter, and sometimes flutters can actually transmutate during a procedure. So here's an example of a left atrial flutter, CS12 catheters. I apologize for this. It is CS12 is located at distal CS os over here in this example. And so what you're seeing is a mitral flutter. And we are ablating along from the LIPB to the mitral annulus. And what you see over here is something very fascinating. Do you see this? The left atrial flutter has actually terminated. And now what you're seeing is actually right atrial flutter. So these kinds of things are very important to keep in mind, to look at how one flutter can be terminated. And you really have to be watching this live during a case. So these are the kinds of phenomena, and this is not uncommon. And this is something that we're getting, and of course we proved that this was right atrial flutter and terminated it by ablating the tricuspid IVC isthmus. One other additional point to be kept in mind is it doesn't take much. It is not as if you're dealing with a thick isthmus. Sometimes even the tiniest region is enough to sustain any flutter, and I think this is very important for post-MACE flutters. Here's an example where this was a tricuspid valve annulus flutter, and what you just see is the tiniest of the tiny area that was able to sustain a tachycardia at the exact same cycle length. So this is worth remembering. And one of the new findings that we are seeing nowadays with arrhythmia cases is even right atrial flutter actually has epicardial components of its circuit. So you're going to be seeing more of these kinds of tough cases where termination of flutter sometimes is all this line didn't matter, and what mattered was just these, exactly the 4 areas from which you were able to record a potential. So it's worth keeping that point in mind. And in your post-MACE cases, of course, depending on where the lesions were placed, you're going to be dealing with even more complex circuits. And last but not the least, and maybe you can comment on this, Louis, is if you're not able to make sense of entrainment and mapping in a case, sometimes it's well worth going in and completing a wide area circumferential ablation. So today, in the case that we're going to be hearing from both Natalie's case in the lab and also with the case that Miguel and Fermin are doing, these are points worth keeping in mind. So can we connect to Dr. Garcia's lab? Go to Dr. Garcia's lab, lab 3 first, please.
Catherine, please introduce everybody. My name is Fermin. We have Miguel, Carlos Tapia, Catherine. Good morning. Good morning. In anesthesia, Dr. Vasquez, Dr. Trillos, nurse Jacqueline Camer, Diego, Natalia with St. Jude, and on the part of EP nursing, myself and another nurse. Well, I didn't catch the name. Good morning. If you can hear me, I'm going to start presenting the case. The case that we are doing is a female patient. She's 74 years old. 4 months of a feeling of sustained palpitations and presyncope. On systems assessment, there is a moderate deterioration of the functional class, important history, a diagnosis of paroxysmal atrial fibrillation with flutter, diagnosed for the first time in 2000 with hypothyroidism, hypertension, sleep apnea, and obesity. She has been taken to isolation of pulmonary veins on the dates that you can see, and at present anticoagulation management with apixaban and propafenone and carvedilol. They are all talking at the same time, and all the microphones are getting into my ears. I'm so sorry, Dr. Chief. In April of this year, she had an organized tachycardia, and we suspect a flutter. This Holter is also recent, and we can see an evidence that there's alternation with a symptomatic Brady arrhythmia and tachyarrhythmia, mainly AFib and atrial flutter. We made an echocardiography in a past admission, and the TEE rules out the presence of thrombi ejection fraction, which is mildly compromised of the left ventricle and mild dilatation of the left atrium. 29 milliliters per square meter of indexed flow. CT of pulmonary veins with unusual anatomy. Fluoroscopy doesn't show significant alterations, and I summarized the case that was done in 2016. This was the latest procedure. There is evidence in that procedure that the pulmonary veins in the voltage map in flutter, the pulmonary veins are isolated just like the posterior wall as well. And at the time of performing the procedure, we find a tachycardia. It seems to be a flutter and it has perfect entrainment from the mitral isthmus. Therefore, we diagnose perimetral flutter ablation is done endo and epicardial ablation of the mitral isthmus, and at the end of the procedure, we find a bidirectional block of the isthmus. This is the final set of ablations, and after performing the lesions of the mitral isthmus, there is evidence of focal tachycardia in the anterior wall of the appendage, which is solved with the ablation. These images of the present CT are to show the characteristics of the mitral isthmus of the patient. It is a long isthmus of 47 millimeters approximately, and the ratio here on the right image, the CS ratio with the branches of the circumflex and the mitral isthmus. The relationship, we have a patient with paroxysmal atrial fibrillation and atrial flutter, hypertension, sleep apnea, obesity, and hypothyroidism. Dr. Fermin? Hola. ¿Nos oyen, Chief? Can you hear me? Le cerraron el micrófono al Dr. Chief, por favor. Dr. Chief, sí, los podemos escuchar, sí. Sí, los oímos. Ya vio la presentación del caso.
Hey, can you please speak in Spanish, please?
Lo que hemos hecho hasta ahora, Diego, pon el mapa completo en grande. Empezamos con
Just the map. Please remove the EKGs. Just the maps. The maps. Okay. We start with this map. It's a voltage map of the left atrium, as you can see. We're done with precision. We are using the St. Jude precision in this lab. We use the St. Jude navigation catheter. It's a 20 millimeter catheter. We thought it was the best size that we needed. And as you can see, the pulmonary veins are all isolated. The posterior wall is isolated. Please turn it around. There is a fractionated substrate component. I don't know if this is because of a prior ablation in the septum and the anterior portion of the right pulmonary veins. Turn it, please, Diego. The appendage, there was an atrial tachycardia, which they ablated the os of the left atrium, and you can see the remnant of the ablation line that they tried to do for the mitral flutter in the latest procedure. After doing this, then please give me the image number 1. We paste to check whether, yeah, we can do it live actually. Why don't you paste, please? Paste from the lasso. We determined that the mitral line, please give it to us live. The electrograms, please, live. Give us the electrograms live. Give it to us in the live monitor, please. Fermin. You can see there that we are capturing in the lasso the CS is distal to proximal, and this makes us think that the line is not blocked, and it paces from the distal CS. Please pace distal to the CS.
This is above the line. This is the ablation catheter. The electrogram is earlier, so we don't have bidirectional block. On that basis, well, you can stop pacing now. We know that we don't have block in the anterior mitral line. or inferior rather. And we decided, due to time reasons and to do something different, we decided to assess whether there was a possibility to map. And this is an image that shows in the lower aspect of the live X-ray. Can we see the live X-ray? One single image with the X-ray, not the map, but the X-ray. We did a venogram, and here we can see Marshall's vein moving upwards prior to the biosense valve in the proximal aspect of the coronary sinus. And now I'm going to give the microphone to Miguel. We decided to cannulate the vein in order to show the anatomy and the relationship between Marshall's vein and the coronary sinus. And the current image I am showing you, where we have the circular catheter above the line. The ablation catheter is on the left lower pulmonary vein, and you can see a wire on Marshall's vein and the relationship of these three structures in fluoroscopy. So I will give the floor to Miguel. Miguel y Fermin, por favor. Well, we have gone through the jugular vein, and here we have placed the coronary sinus sheath as the one used to place electrodes or leads of the left ventricle. We go into the coronary sinus. Can we see the prior angiography, please? So this is the first one. The first angiography, please. So through the sheath on the coronary sinus, we have placed a Lima guide catheter. As you can see, it is posteriorly placed. When we have contrast medium in the Lima catheter, the Marshall vein opacifies very easily. And once we have the ostium, the catheter in the ostium of Marshall's vein, we advance an angioplasty guide with a preloaded balloon. We chose a 2.25 balloon or 1.5, I don't remember. And we placed the guide wire in the Marshall vein and then the balloon. We are trying to record signals through the wire in the Marshall vein, but we are experiencing some technical difficulties because we cannot record the signal. Usually, okay, it's ready. Can you show me the map? The NAVEX map. Here you can see the guide wire. Well, no, this is ablation. No, this is the guide wire. The green dot is the guide wire. The ablation catheter is in the pulmonary vein. Can you show me the signal that we are recording through the guide wire? So we are pacing. Did you pace? Well, I don't know what happened. Please don't pace. I simply want to see the signal which is being recorded. I will try to filter. It's usually very noisy, but with proper filtering, you can see the unipolar signal, which is low amplitude and very fractionated. I am recording signals of the most distal aspect of Marshall's vein. Miguel, ¿podría explicarnos?
Bueno, se ve que hay una señal unipolar. Pongan solamente los electrogramas.
¿Qué tanto?
Pon solamente los electrogramas, la pantalla.
Well, this is the screen with the live electrograms. Although it's very noisy, I think that the problem is in this connection over here. Well, here we can see it's a low amplitude signal. We are trying to reduce the noise. We can pace through the Marshall's vein using this system. In fact, we have a paper published 2 years ago where we did high-frequency pacing to unmask vagal response, and we got asystole. We also obtained induction of atrial fibrillation, so I don't think that's a good idea in this case. Another interesting point is that I can retract the balloon and the guide to get signals at different levels of Marshall's vein. I am going to withdraw the guide a bit. Well, this is to show where we are with respect to the scar. Well, let's do an anatomic map using NAVIX. The Marshall vein is quite large, fortunately for us, and has a lot of branches. I am quite up in the vein. I am going to come to a more proximal position, but I don't want to lose the cannulation of the Marshall vein. It was not difficult, but we don't want to repeat the cannulation of Marshall's vein. No, I prefer not to do that again. Well, when I go too proximal, we lose the NAVIX. Let me move up again. ¿Tiene clips en la guía?
Clip on the wire.
Sí, tenemos un clip caimán
Ahí está
en la
bastante
guía.
limpio.
A mí se me cayó aquí el speakerphone de la oreja, no sé dónde está.
Sí, para
Can you
ver.
guys make a quick comment about the connectology and how much of the wire is exposed within the vein?
So we're using the vision wire, so all you get is the last centimeter of the
Ya lo
wire.
único que vemos
just
es
say
el
that in
último
Spanish,
centímetro de la
Fermin.
guía, pero por favor hablen
Estamos
español.
usando el vision wire de Biotronic que está cubierto.
Up to the distal aspect of 1 centimeter, but we have less than 1 centimeter because the balloon is covering, it's quite deep. As you can see, let me show you an image in order for you to see it in a magnified image. This is a higher magnification, and you can see the relationship. The balloon is covering. You can show the X-ray image only. Let us see just the X-ray image. Sí, bueno, es maravillosa esta imagen. Depende de qué tanto de la guía está expuesta. This is a magnified image. Here you can see, well, it's rather dark, unfortunately. So here we can see the relationship. If we push the guide upwards, you can see it moving up and down. Sí, yo lo estoy señalando con el
The
láser.
lasso is on the appendage side.
The lasso is on the appendage of the line. Here you can see it on the map, and the ablation catheter is in the pulmonary vein. And you can see the distance between these two structures and the coronary sinus and the vein. As you can see on the signal from the wire, from the guide wire, there is an electrogram, a small electrogram. So aquí podemos ver la señal unipolar de la guía. Puedes hacer un comentario.
Image, and that is,
Lo amarillo.
you know, when you looked at the venogram, the length of the vein was not as long and as deep as where the wire is now.
Yeah.
Is that common
That's
in your
very
experience,
common. That's
Miguel?
very common. It's remember, it's a non-selective venogram that we did through contrast.
Can you say
injection
that in Spanish, please, Miguel, for the audience benefit?
What Dr. Shinkumar was saying is that apparently the wire is more distal in the Marshall vein. It seems that we are beyond the vein. The question is that the initial venogram of Marshall's vein we did with contrast injected in the coronary sinus is a non-selective venogram. As soon as we remove the wire, we are going to inject contrast medium through the balloon, and we can see the real extension of Marshall's vein. Well, in fact, Miguel, we are not recording electrograms of Marshall's vein. No. This is the epicardic fibers in the lateral wall. We say it's the Marshall vein, but we have to make it clear. Sí, estoy mostrando.
Fermin and Miguel, I'm actually showing a slide for the audience. Here's an example. This is a vein of Marshall case we did at UCLA. What you see over here is an injection. You see how if you selectively inject the vein of Marshall, it connects all the way to the subclavian. So this is a tiny little left SVC if you look at it, right? And this is a slide from Dr. Valderrabano's paper. So sometimes if you do non-selective injection, the vein may come up to here, but then they're able to thread the wire quite a distance up. And this is the high frequency stim. You can go back to the lab, please. So just remember this point. This is the structure that they're mapping, and that's epicardial. So,
Exactly.
was that useful?
So the idea is
Okay.
that the vein of Marshall is just a vascular route to reach the epicardium. No es que estas señales vengan directamente de la vena de Marshall como estructura eléctricamente
Perfect.
activa, sino que simplemente es un vehículo para llegar al epicardio. Tenemos publicado,
Okay.
está impress
Sure.
en Jack, todo un atlas de la anatomía venosa, de todo lo que hemos aprendido inyectando contraste en la vena de Marshall y en otras. Yo creo que ya
No,
podríamos...
¿sabes lo que sería bueno hacer? Como está sugiriendo aquí el
As Dr. Tapias is suggesting, to pace the coronary sinus 1, 2, to see what comes earlier, the Marshall's vein or the endocardium. Miguel y Fermin, vamos a cambiar a la
Progress of the cryo case, and we'll come back to you in 15 minutes.
Chief, wait a second.
Yes.
This is an important point. Last thing.
Okay.
Look at the pacing signals. We're pacing from distal CS.
Can you guys
Estamos
switch to
simulando
the
el
pacing
CS
screen?
distal.
We are just seeing the fluoro here, please.
Can you switch
Ponlo en vivo las imágenes.
Beautiful. Es conexión de la vena de Marshall.
Pongan los electrogramas en vivo, por favor. En
Oh, now we are
pantalla
seeing
grande, en
EGMs,
pantalla
good.
grande. En pantalla grande, los electrogramas en vivo. Chief, this is very important.
Yes, yes.
Lo que
You
estamos
go ahead, say it in
haciendo es-
Spanish.
Estamos estimulando del seno coronario
Pacing
distal.
from the distal coronary sinus to the ablation catheter above, endocardically above the ablation line. And the electrogram of Marshall's vein is earlier than the endocardic. This suggests an epicardic connection in the isthmus. Is it clear? Because this concept is very important. This is what we see in the electrogram. We are doing an activation, a pacing mapping of conduction through the isthmus of the line that we did before. And the Marshall's vein electrogram is earlier than the endocardium, despite the fact that it's further away. It's further away. Yes, this is excellent. Si este es un caso,
Doing this.
Yes.
Okay, I think what we should do now, yo creo que deberíamos poner alcohol durante pacing en
to
el...
administer alcohol during pacing in the appendage to see how it reverts. I am not pushing the limits, but this may happen sometimes. So let's begin. Alcohol injection, would you agree? No, they are going to switch rooms now. Por
The
favor.
room and we'll come back to you.
Oh, okay. Si quieres tratamos de inducir.
It's actually very nice. Sometimes they actually get block across the mitral isthmus post alcohol injection. So can we go to the cryo lab? Gentlemen, you're live with us. Can you give us a quick update on your case?
No oigo nada.
Ya están escuchando.
Pero tengo que escuchar allá qué es lo que me están diciendo. Híbrida online.
Yeah. Are you able to hear me?
Yes, hi,
Perfect.
Chief.
Perfect. So why don't you give a very quick snapshot of your case and give us an update of where you are?
Okay, thank you, Chief. Buenos días a todo el mundo. Bienvenidos acá a la sala híbrida. Estamos con el doctor Fernando Escasuso. Mi nombre es Diego Rodríguez. el grupo de enfermeras de...
Group of nurses from electrophysiology, Diana, Daniela, the anesthesiology group that is also helping us to work on this case. So let me present the case very quickly and give you an update of where we are at this point. This case is a 30-year-old patient with paroxysmal episodes of atrial fibrillation refractory to treatment with metoprolol and propafolone. This patient has no deterioration of the functional class, and he has overweight with a BMI of 29 per square meter. This is a patient who was being treated with metoprolol, propafenone. We stopped the medication 1 week ago. The Bigatran 150 milligrams every 12 hours. The last dose was taken today in the morning, and atorvastatin 40 milligrams during the day. On the screen, you can see the baseline EKG, which essentially is normal. The ECG of one of the episodes of atrial fibrillation in December 2016. We can clearly see here the atrial fibrillation, irregular RR with rapid response. And this patient underwent a 24-hour Holter documenting paroxysmal episodes of atrial fibrillation, as you can see on the lower left graph, alternating with sinus rhythm with a rhythmic load of 43% in the 24-hour Holter. A transesophageal ultrasound, which was done on July 11. Basically, it's a normal ECG with no thrombi in the left atrium, ejection fraction 63%, and a volume of the left atrium of 25 milliliters indexed to the body surface. Because of age, we decided to do an MRI of the heart prior to the procedure. The MRI was reported normal. You can see the 4 pulmonary veins, which are independent with no important alteration. We also did a late sequence, which was also normal. So with the diagnosis of symptomatic atrial fibrillation with chest back of 0 refractory to treatment in a very symptomatic patient, who doesn't want to continue pharmacological therapy. So we brought the patient for cryoablation procedure. I don't know whether at this point we could...
I think it'll be good if you continue, because we're going to give them a break in 10 minutes. So maybe you can continue for a few more minutes. Tell us where you are, and then we'll open up to the audience questions.
Okay. ¿Podemos poner, Rodrigo, el eco?
Can we show the ultrasound, please? Un segundo. Vamos a mostrarles algunas imágenes. Well, we began this case with a non-fluoroscopic approach trying to minimize exposure to X-rays. As you know, cryoablation procedures tend to have higher X-ray exposure. We did the baseline images in home view, right ventricle, left ventricle. We don't see anything special in them. Here you can see the left appendage, which is thrombi-free. We see the left upper pulmonary vein and the left appendage with no particular images in the lower aspect, and the entry of the left upper pulmonary vein. You can see the guide wire coming into the left atrium. This is the puncture site we chose. It's somewhat posterior for cryoablation. It should be more anterior and inferior, but in fact, this is a normal atrium. We had some difficulty in moving more anteriorly, but here we did the transeptal puncture with no complications. We used a lamp 90 sheath as the initial approach for the transeptal puncture. And then when advancing the sheath, we changed it for a high support guide wire, an Amplat high support guide wire to put the sheath through which we are going to pass the balloon. At this point, I will show you. Well, I will give the microphone to Fernando rather to show us the images and to tell us what has been done with the left upper pulmonary vein, which has been already isolated. So could we pass the microphone to Fernando, please? Well, good morning. So here, this is a cryo balloon case. I am going to show you how we began for the isolation of the left upper pulmonary vein. This is the circular catheter that you see here. This is the Achieve catheter, which is an octopolar catheter. It has 8 poles, so we can develop 4 bipoles. It's in a posterior position to be advanced inside the upper left pulmonary vein. So here we are advancing the catheter, and we are checking the passage through the left upper pulmonary vein. Here we will see the electrograms that were recorded, and we are also showing how we proceeded to inflate the balloon to place it as antrally as possible. The same image being repeated. Good occlusion. In this case, we use contrast, which is a good grade 4 option. We don't see any losses in the lower pole of the vein. So we then apply temperature. We can see that the drop in temperature must be consistent with time. We have to keep the first 30 seconds a linear relationship of minus 30 degrees for 30 seconds. Here we can see the cryo administration. Here you can see the records of the 8 poles. Only the distal pole is more towards the ridge and in contact with the appendage. Here we can see the rest of the vein, which was disconnected in the first 45 seconds. This was the treatment for the first vein, and we repeat the same sequence of treatment for the second vein, which is the lower left vein. Here you can see the fluoroscopic image, the inflated balloon in the antral segment of the upper left pulmonary vein. And this is the contrast media injection. You can see that there is no loss of contrast and a full stained vein. Do we have any questions? Puede resaltar el
You have to
punto.
make sure that there is a good attachment of the balloon, because this is an important area. If you see a lot of leaks, you may have to actually reposition the balloon and also adjust the sheath.
Bueno, en realidad en este punto lo que vemos es que el contraste se queda dentro de la vena y no.
It's inside the vein and there are no leaks or retrograde flow. Sí, es.
Apposement, the apposition here is excellent.
Yes. Yes, this is the good to gain the cryolation, the cryolation. Y fíjense, ahora podemos ver en el polígono.
We can see the vein following the application of the first lesion of 240 seconds with no electrogram and just more appendage in pole 1 and 2, because don't forget that we are in the upper left pulmonary vein. Esto está maravilloso.
Once you finish the other veins, could you also save some good sequences when you're working in the right upper pulmonary vein, so that we can, when we come back after the break for the audience, we can talk about protection of the phrenic nerve, which is a kind of an important concept that I think the audience and all of us would be interested in.
Yes, absolutely. The next vein that we will to treat is the superior right vein, so we will use all the techniques to avoid the phrenic lesion.
Sure. So
thank you.
Thank you so much, gentlemen. We are going to give the audience a coffee break now on time.
Okay.
And when we come back, we're going to check in with Andrea Natali, and then we'll come back to you and we'll talk about the right superior pulmonary vein.
Okay, it's okay.
Thank you. Congratulations. I'm glad it's going well.
Okay, you're welcome.
Any questions from the audience before we go get our coffee break? When we come back, we're going to go back to Dr. Natali's case, which is a patient who has 2 mechanical valves, and it's going to be an AFib. It'll be interesting. And when we come back for the cryo case, we definitely should talk about the right superior pulmonary vein and how they can protect the phrenic nerve. And when we go back to Fermin and Miguel Valderrabano's case, we'll talk about how alcohol injection and to see if it improved the mitral conduction block. Any comments from the audience?
Yes. Here.
Yeah, question here. Can you guys cut down the volume, please?
Estimular 800.
No vimos ningún sistema de protección del esófago. En la crioablación no hubo ningún sistema de cuidado.
Could you repeat that? There was no translation yet.
We didn't see any system to protect the esophagus in the cryoablation. What do you, some comments about that?
No. Sorry, there was so much noise, I thought. Thank you for that question. So there is going to be a special discussion. We're going to make a comment about esophageal protection. I think the esophagus is at risk irrespective of the energy source we use. And I'm sure many of you have seen the scary complications that have occurred, including AE fistula in patients who have undergone cryo. This is a question that we'll pose to Louis again when they come back. Our strategy at UCLA has been to always do esophageal contrast placement. And then we, of course, observe it. It's very hard to interpret what really is the temperature means in the esophagus because there isn't enough data. But we try to stay away from it if it's incredibly close. We try to see if we can use the esophageal probe, using a more tighter probe to see if we can move the esophagus away. But I do think that is a concern, and you have to be very careful about where you place it, because that entire area can become an ice block. But I think in this case, they hadn't placed the contrast in the esophagus, and let's ask that question to them live when we come back. But thank you for asking that. That's a very important concern. Other questions or comments? And we can, of course, pose this to the team when we go back. Okay, in that case, we are doing well on